Hello, I'm Prieto-Alhambra. I'm a professor of pharmacoepidemiology at the University of Oxford, and I'm going to be talking to you about the work we've done catalyzing a global pandemic response with the Odyssey COVID Studyathon and the Eden Data Partner. Hello, I'm Prieto-Alhambra. I'm a professor of pharmacoepidemiology at the University of Oxford, and I'm going to be talking to you about the work we've done catalyzing a global pandemic response with the Odyssey COVID Studyathon and the Eden Data Partner Call. These are the 4 topics I'm going to be covering. I'll start by telling you what's in this for us and why did we enroll in this joint venture. Secondly, I will cover the Eden and Odyssey COVID-19 collaboration. Third, I will explain how we unraveled COVID-19 as a community and how the level was as expected in the detail in doing this. And finally, I will cover how we learned from the past. So something we've learned in the last few months is that, as the Odyssey community already knew, the data is a must. It's a necessity that we have to create knowledge, but it's not the only thing we need. And there's been, as you are very well aware, very hard learnings from the exercise of analyzing data all around the world. And there has been a really bad example of poor science led by the Sargisphere data, people who basically provided information that hasn't been corroborated and that has been deemed as fraudulent potentially and led to the retraction of 2 big papers. This is why we believe that it's very important that we keep working as data partners and not as solely data custodians to provide data provenance, data knowledge, and of course to work as a community to create knowledge together. This is not something new. There's a lot of bad practice in data sciences from the past. This is a slide that I've borrowed from Professor Ripsack, where you can see there is very heavy evidence of p-hacking with loads of reports of observational data. Actually, more than 85% of exposure outcome pairs with a significant p-value below 0.05. And you can see how actually, sadly enough, there is a lot of clustering around these thresholds. So with that in mind, how can we help with the Odyssey community? I think we are helping a lot by creating and sharing ETL documentation, data quality dashboards, protocols, standardized analytical packages, study diagnostics, and interactive results that can be inspected in full by the community. I think that by doing this, we are encouraging others to do the same, and I believe that this level of transparency is needed to improve the reproducibility, interpretability, and trustworthiness of our work. This is the full transparency agenda that we're following in this particular study that I will cover later about the safety of hydroxychloroquine. We noticed that we had to register a full study protocol, and we did so in the EU PAS register held by the European Medicines Agency. We shared our phenotype definitions and analysis specifications. We shared all our analytical code. We posted our findings in preprint in medRxiv, and we made all our analysis results available in the form of a web application. So what did Eden and Odyssey do to help the COVID-19 response? It all started with a very nice plan to host more than 300 people in Oxford for the Odyssey Europe Symposium that was going to be held in late March, talking science, learning, and hopefully also having some fun with some of our friends in the community. Unfortunately, we had to cancelled that meeting to help contribute flatten the curve at that time. And we managed to do something remarkable. We rallied together. We held a 4-day study-a-thon hosted virtually and convened more than 350 participants from 30 countries, wrote loads of messages, held communications online, and wrote 9 protocols, 13 study packages, more than 350 cohort definitions, and you can find all the news in that link over there on what we did over those 4 days. 3 things that we did in 4 days that nobody had done before at that time included the first large-scale characterization of COVID-19 patients admitted to hospital in Europe, US, and Asia, the first prediction model externally validated internationally on COVID patients to inform shielding strategies, and the largest study ever conducted on the safety of hydroxychloroquine. This is what the data network looks right now. We have data from the USA, from Europe, and from so far 2 countries in Asia. And we are looking forward to having more people from Asia and Oceania joining this collaboration. We have for now gathered data on more than 4.5 million people tested for SARS-CoV-2, more than 1.2 million people tested positive, and almost 250,000 people diagnosed and admitted to hospital with COVID-19. In Europe, more specifically, Eden is mapping data from 25 data sources around the continent, including very varied data sets like Health Data Hub claims data for the whole or 99% of the French population, UK Biobank, which is a very rich data set with 500,000 people from England, Scotland, and Wales, and Istanbul University Faculty of Medicine, which is, I believe, the first time we will be mapping data from Turkey, covering more than 1.5 million active patients. Now, how did we phenotype COVID-19? We did, for the first time, I believe, in the history of Odyssey, have to create definitions and phenotypes for a condition that was entirely new to us. The ideal definition one could think of when confronting such a situation should be clinically relevant and sensible, should be actionable, interoperable for different types of data, transportable across a network of international databases like ours, sensitive, and specific. And you can imagine this is not always possible, but if you manage to do that, you will be celebrating just like that. There are ways you can operationalize the definition of COVID-19. You can look at tested positive in a real-time PCR for the virus. You can look at a clinical diagnosis with COVID-19. You can look at hospital admissions. You could look at ICU admissions. You could look at death with COVID-19 and potentially many other operational definitions. So this is what we did in CHARYBDIS, which is the main characterization effort in the community. We created a cohort of people tested for SARS-CoV-2, a subgroup of these that were people tested positive for SARS-CoV-2 and therefore infectees. We then have a group of people that encompasses people tested with COVID-19 for COVID-19 who gave positive, but also people with a clinical diagnosis that did not necessarily get tested, and this happens a lot in many countries that were overwhelmed with insufficient testing capacity, like Spain, the UK, or some part of the US during the first wave. We then have a group of people with hospital admission with COVID-19, and we do have, of course, people admitted to ICU with COVID-19. This is what happens, and I've just taken a few examples here of different types of different types of data, hospital EMRs, claims, GP databases, and ambulatory data sets. And you can see here how, for instance, looking at tested positive eliminates quite a bit of these databases and leaves us only with 4 databases out of a total of 8. If we then accept that a clinical diagnosis is sufficiently of good quality for us to continue with our research. This is the cohort, the most inclusive cohort, which is clinically diagnosed or tested positive, and that enables us to include many more data sources. In this particular example, we are gaining IQVIA open claims, ETC from the Netherlands, and IQVIA DA Germany by including people diagnosed without the need for a test. Here, when we look at hospitalized with a test positive, we are left with just 3 databases. But if we then accept again COVID diagnosis as a valid definition, we would suddenly be gaining an additional one here, IQVIA open claims. And then if we look at admitted to ICU with a COVID diagnosis or test positive, we have a different set of databases. This is what it looked like in a table format where you can see how different definitions apply to different data sources and preclude the inclusion of other ones. And this is what it looked like in numbers. So when we are requiring test data, we start from a total population of almost 4.5 million patients. That drops to 8% test positive. And then if we want to go for hospitalized with a test positive, we are left with just over 28,000 people. If we are happy to admit, to accept clinical diagnosis or test positive as the 2 potential valid definitions of COVID-19, then numbers jump up and we end up with more than 240,000 people hospital admitted and diagnosed or tested positive for the disease. And in summary, different phenotypes will provide different levels of confidence with the definition of COVID-19 and potentially also reflect different disease severity, like diagnosed versus hospitalized versus ICU admitted. They will accommodate also different types of data and different geographical areas, and that has to be borne in mind when you are doing this kind of research. Something that I think is quite important is that things will change over time with increasing test capacity, different types of tests, and different patterns of community transmission. My final point is going to be to cover the results of some data that we managed to put together using retrospectively collected information. When we started our study-a-thon, we realized that hydroxychloroquine was being heavily used to treat COVID-19 around the world. In fact, we knew that from data from Spain, it looks like around 70% of people admitted with COVID-19 were getting treated with hydroxychloroquine, a cheap generic drug, relatively safe, but with some known side effects. And indeed, we knew that that medication had been used for over 40 years for other indications, including rheumatoid arthritis, systemic lupus erythematosus, or malaria prophylaxis. Indeed, data from many of our data sources indicated that the drug was being heavily used to treat COVID-19, in some cases for over 80% of the patients, like in these HM hospitals from Spain. So we looked at the data and we realized that we had historical data from more than 900,000 previous users of hydroxychloroquine to treat rheumatoid arthritis. And we then wanted to learn on the safety of this medication. We chose sulfasalazine, a similarly indicated rheumatoid arthritis drug, as an active comparator. And then secondly, as we knew that there could be potential drug-drug interactions with azithromycin, we looked at the safety of the combination of hydroxychloroquine with azithromycin versus hydroxychloroquine with amoxicillin as an active comparator. We use routinely collected data from Germany, Spain, Japan, South Korea, the US, and the UK. And we did both a cohort analysis, but also a self-control case series that I will not have time to present today. We wanted people who had a history of rheumatoid arthritis and were users of these drugs, and we stuck to adults and with at least 1 year of data visibility for inclusion. We were most interested in a 30-day follow-up because that was the treatment regimen used for hydroxychloroquine in COVID-19, but we also did a non-treatment longer-term analysis. Excuse me. We used, of course, federated analytics using the cohort method in Odyssey. We built large-scale probability scores, used a number of diagnostics to make sure that the analyses were robust, and then used probability score stratification and negative control outcome calibration. All the results from this study are fully reported in this link that you have here for inspection. And these are the numbers. We had more than 945,000 users of hydroxychloroquine, more than 300,000 users of sulfasalazine. And when we looked at the cardiovascular outcomes that we thought could be affected with the use of hydroxychloroquine, we found no increased risk in the short term of any of these cardiovascular events in any of the provided data sources. But unfortunately, when combined with azithromycin, we noticed that hydroxychloroquine led to a doubled cardiovascular mortality and also a milder but still significant increase in the risk of both chest pain, angina, and heart failure. We didn't notice any increased risk of any of the other long list of side effects that we looked at. And this data has now been published in Lancet Rheumatology and fed regulatory warnings from both the European Medicines Agency and the US FDA, amongst potentially other regulators. We then did a follow-up study when we heard that the European Medicines Agency was looking at the neuropsychiatric safety of hydroxychloroquine as well. And we completed this within weeks of listening to the regulator and found no increased risk of depression, suicidal ideation, or psychosis amongst new users of hydroxychloroquine with rheumatoid arthritis. This has now been published in the Rheumatology Journal. As a consequence of our work, we saw a great impact on the use of hydroxychloroquine. As you can notice here from many data sources, hydroxychloroquine increased in use in February and March dramatically, but then dropped also dramatically in April, May, and June. I would like to finish by thanking all the colleagues that collaborated in very hectic days during the study-a-thon, but also in the following months to do all this work, people that gave their time to the community to contribute to all the work that I've explained here. Thank you very much to everyone, and I will be delighted to hear my colleagues who are speaking next. Thank you so much.
And next up, we have Seng Chan You.
Hi everyone, I'm Seng Chan You from Aji University, and I'm really proud and honored to present about the Korean project for providing COVID-19 data set. The project name was Open Data for COVID-19. As you might know that in the early phase of this pandemic, the Korea is one of the most dangerous countries in the world. So as of March, you can see the striking instance of this pandemic and the spread of the speed of the spread of this pandemic in Korea. At the same point, we witness a lot of the false news. There is really conspiracy theories, or there are really many false scientific reports, especially the most privileged papers, including Lancet and NEJM, retracted the controversial COVID-19 studies based on the fake data from the Surgisphere dataset. So it is tremendous. It is truly the failure to resolve basic concerns about the data during the course of the normal peer review. And it lacks the reproducibility and open science. So as many colleagues started their presentation about open science spirits of Odyssey, actually I think that it is really crucial that open science promotes citizens' trust in science. So create citizens' engagement leads to active participation in scientific experiments and data collection. So as announced before, a new initiative for the collaborative research against COVID-19 was launched. And South Korea decided to share the world's first de-identified COVID-19 nationwide patient data with domestic and international researchers. In conjunction with ACEI COVID-19 Datathon during the March, the Korean nationwide patient big data was shared through the dedicated platform. So in the regular briefing on March 27th, the Korean CDC announced that the launch of the global research collaboration project on COVID-19 in conjunction with ACEI. So the scope of this project is providing the patient-level data of COVID-19 through the distributed research network. And as of May 5th, the total number of claims was 400,000, and the total number of patients was 200,000. And among them, the confirmed cases were 7,000. All data have been provided in two formats. One is the original HERA data format, and the other one is Homopsitian version 5. Here, the HERA is the Korean National Insurance System, and it holds the nationwide information from the national insurance. Again, the researcher should need to join the website to launch their to proceed their own study, and they need to register the project to the website, and they need to upload analytic code with their IRB approval or waivers. Then HERA executed that analytic code inside the HERA's data asset, and then the researcher can receive the result from the HERA. I'm really proud of that. This decision was not made by one single researcher or the single medical institution in Korea. It was made by the Korean government to share this really precious data across the globe. So as of May, total of 300 projects were registered from 32 countries. You can see that not only the Korea, that many researchers from United States, UK, Israel, Canada, Italy, Australia were launching and starting their own project for COVID-19 by using these data sets. So, but there is challenges. So this is my final slide. The adoption and application of a new research method where the research from all around the world can join and carry out a collaboration for specific specific study was not so easy, especially because of the open source. Most of them use open source analytic tools, including R, Python, or ELF, and it was not easy to implement all the environment on the HERA's closed intranet environment, because the HERA's closed intranet environment does not allow to connection to the intranet. So meanwhile, the ACEI actually developed a new system. We upgraded the hardest environment, and then we upgraded many essential packages for our studies. So it was really challenging, and we need to figure out how to solve this problem in the future collaboration. And this is my final slide again, and thank you for your attention. And I'd like to turn it over to Kristin to show the international effort for COVID-19 to construct international COVID-19 data network.
Thank you, Chan. Well, it's hard to follow you and Danny. You have such amazing work that you have done in Korea. Thank you all for having me this evening. And it's my evening, I should say your morning. I am really delighted to talk to you about the science that continues to evolve from this amazing collaboration. As I mentioned, I'm Kristin Kostka. I'm an associate director at IQVIA. I work with Mui and Christian and many of your colleagues in APAC. And I am really excited to talk to you about Project CHARYBDIS, which you probably hear about and wonder. And it's really around the natural history and predicting patient outcomes, building a knowledge base to inform us as we go into more sophisticated designs. And this slide is really popular, so I'm not going to spend too much time here, but it's worth saying how lucky we are to have such an amazing network. Thank you so much to our collaborators who have worked tirelessly. I am extremely grateful for all the hard work that Chan and his colleagues have done with converting HERA, with the other hospitals in Korea. I know our colleagues at Nanfang have worked very, very hard. So huge thank you to all of you for all of your work as we continue to grow our network. So what is CHARYBDIS? It is characterizing health-associated risks in your baseline disease in SARS-CoV-2. And it really has two focus in its first iteration. We are looking at the description of baseline demographics, clinical characteristics, treatments that we can see, albeit in some cases quite limited, symptoms and outcomes of interest in all of those different cohorts that Danny talked about earlier. We have an interest as well where we could to make comparisons against another viral population. In this case, we looked at influenza patients in a single year compared to the COVID-19 population. And George mentioned some of our findings from early work that informed wanting to keep that comparator. So why are we doing this? Well, it's worth saying that there are, of course, a growing number of studies that are coming out. But when we first started, there weren't as many characterization studies out there. There were small sample sizes. There weren't as multi-center. There wasn't a lot of granularity in the information and even the settings that we were looking at. And of course, the representation globally has evolved, but in the beginning, there wasn't a lot of information in different places. And we have a lot of unanswered questions that we wanted to investigate. We were really curious about who gets tested, who gets infected, and who gets hospitalized. We have an interest to stratify on age and gender around the prevalent conditions that are in someone's current disease state, around prior treatment history. And even where we could, we wanted to look at symptom onset and understanding the patient trajectory and really how this is different than things we had seen. Of course, back when we first started, we really just didn't know what to compare, and we were quite curious around a number of axes. And so we see it as a comprehensive understanding of the natural history of patients, and we see these as equally important parts of stitching together of the fabric of what will inform other studies that we'll design in the future. And as Danny mentioned, we had the ability to be quite robust in our study here, and we had many types of different combinations of what qualified as a COVID diagnosis. And this includes everything from people who are tested to tested positive to combinations of diagnosis and measurement codes. And of course, we did similar populations in the influenza comparator. We have a number of stratification factors that were built for this particular analysis, and a huge thank you to the phenotype team, Gautam Rao and Patrick and the entire team, Anna, Aza. They worked really, really hard to build us cohorts to help have really robust definitions, which we can now reuse in all sorts of studies. So if you are doing an analysis and looking for end-stage renal disease, we have quite a few cohorts you can take from us. And the same thing for immune disorders, HIV, and even various shades of pediatrics, pregnancy, and heart disease. So really cool knowledge artifact that's available for all of us to take advantage of, whether you're looking at COVID or other populations. So to date, we have done a lot of work, and you've heard a bit about this, and we see that COVID diagnosis and testing is positive is more common in women, although hospitalization is more common in men. We have some beautiful visualizations we've been rendering to look at comparing these populations. Here is a view of some of our European data partners. You might notice there are not both colors in some of these plots. And as Danny mentioned earlier, we don't always see the whole patient journey. We may only see outpatient information. We may only see inpatient information. And we are comparing that even in some of our visualizations. In our other work, we see across the US network a little more consistency. In these data partners, we had both settings available to us and quite a robust sampling. We saw that amongst age groups hospitalized with COVID-19 are older than the diagnosed test positive. And as we evolve this, we could see this evolution of how people move through this disease state. And you'll see a lot of these plots, these Manhattan plots are quite cool. Thank you to Patrick and to Ed Byrne and to Albert and the team who have been honing these for our studies. You can utilize these if you like these plots. We have code available for you. And you know what we're really seeing consistently in our research is that COVID is no flu, that there is less history of drug use, but there are worse outcomes. And when we say drug use here, we mean medication exposures prior to their diagnosis or their hospitalization. And what's really maybe the most incredible part of the evidence we've generated is that we've only skimmed the surface in the ability to look and analyze the information that has been sent back. So we have this wonderful, shiny application. If you go to data.odyssey.org and you navigate to this COVID-19 characterization CHARYBDIS, there is a huge dashboard here that anyone can play with, and it has all these different combinations. And it really is a powerful resource if you have a question about different combinations of certain stratum. So maybe you're looking at people over 65 who have prevalent hypertension. You can go in there and select that and see counts from the data partners. It's really amazing, and anyone is welcome to use it. And we certainly welcome collaboration if you find insights and want to run with it. We have a lot of papers that we are really lucky to have written on this evidence set so far. The deep phenotyping paper that came out of, this is the very first one, it's in Nature Communications. This was really the first major piece Ed and team worked on, and it helps us set the framework for how to begin these comparisons. And then it's snowballed. As George mentioned, we have lots of preprints out. So we have a study that looked just at people with and without obesity. We were able to get data from partners in the United States, Spain, and the United Kingdom, and they were able to look intently around how people with a history of obesity, how they compare in their COVID-19 natural history and their hospitalization and intensive services utilization. Kind of amazing to see that subgroup. And it's not the only one. We have a study looking at pregnant women. There were about 8,500 cases that they looked into. They did find that despite low mortality rates, pregnancy and maternal outcomes were worse in COVID-19 than in influenza. And you're welcome to dive in. There's more information about this particular paper, of course, on the web as well. We also had a study that looked specifically at testing. Testing, as Danny mentioned, there's a lot of different ways that this is being thought about, especially around access to testing. ACEI, Golzar, and Lana Lai helped lead the thought leadership here and wrote this wonderful analysis looking at the baseline phenotype and 30-day outcomes for people tested. Really, really great work, and there's some wonderful insights around how South Korea and the European and US data compare. So check it out if you're interested. We also had a study that we led looking at HIV in COVID-19. This was led by Juliana Kohler at USAID, a large AIDS research organization that does a lot of outreach. And they don't usually do real-world data studies, so this was quite neat. And she was able to write some insights around across the care cascade, these co-infected patients who received intensive services, so really, really sick with COVID, were more likely to have serious underlying disease and of more serious events at baseline. And they looked at analyses around different stratification of these event cascades. We also had someone do a pediatric study looking at a wide range of medications for inpatient management for pediatric COVID-19. There was a study that looked at dialysis, tracheostomies, and ECMO. And this one in particular was looking around the utilization of these particular treatments. And it was pretty much limited to large claims databases because these were quite small cohorts that we found, but some really interesting insights we would like to replicate as more time elapses. There's a study also on autoimmune diseases that came out of the NDORMS team looking at a whole bucket of prevalent autoimmune conditions. And in future work, as we continue to design this study for next iteration and amend it, we may be breaking this out so there can be more specific insight about type 1 diabetes compared to psoriasis and so forth. So if you're interested and excited about characterizing the amazing journey of how different subgroups of populations move through this disease state, you're welcome to reach out to myself or to Lita or Albert. We are leading the effort here in the MS teams. We have a group that we meet. We are just wrapping 1.0 and going to be designing the next phase of analysis where we extend our endpoints. We look at different treatments and outcomes as we've understood more about this disease state. And a huge, huge thank you, as everyone has been saying, but huge thank you to the community that has been behind us. We really would be nowhere without your support, with your time and energy that many of you put into manuscripts, into helping us with data, helping us run packages. So huge, huge thank you to all of you. I really appreciate it. And of course, you're always welcome to join the journey. You're there today. So I'm going to hand it off now to my colleague, Marc Suchard, who is going to go through and tell you a little more about taking it from characterization all the way into even more cool questions like the ACEI study. Marc, I'm going to hand it over to you.
That was an amazing talk, Kristin. Thank you very much. Let me pull up screen 2. Good morning, good afternoon, good evening, and good middle of the night for our European colleagues that have joined us, like Donnie. My name is Marc Suchard, and I'm a professor of biostatistics at UCLA, but I'm not here to talk about my own work. I'm really here just on behalf of the ACEI team. The ACEI team is a motley but very productive crew of almost 30 individuals in the Odyssey community that include data custodians, informaticists, epidemiologists, and of course clinicians. And hopefully in the next couple of minutes, as I describe a project that we've worked on in the face of COVID, you'll see that we've been able to bring together these resources from the community to provide some real world, yet in real time evidence for an important clinical question. People with cardiovascular disease and hypertension happen to be much more likely to develop severe complications of SARS-CoV-2 viral infection. In relationship to hypertension and cardiovascular disease, there are a couple of drugs, in particular angiotensin-converting enzyme inhibitors, which I'll refer to as ACE inhibitors or ACEIs in this talk, and angiotensin II receptor binders, or ARBs. Together, they're generally called RAS inhibitors, may influence the susceptibility of an individual to COVID-19 and even worsen its severity. So driving this hypothesis is the mechanism that SARS-CoV-2 actually enters human cells by binding to the angiotensin-converting enzyme, specifically number 2, which is most prevalent in the lungs, but also throughout the rest of the body. And these particular types of drugs and chronic exposure to these types of RAS inhibitors may alter, and in many cases we have good pathophysiological evidence that they do alter, both upregulate and possibly downregulate the expression of ACE2, thus modulating the ability of SARS to infect an individual. So very early in the pandemic, this hypothesis generated huge public health concerns. And quickly, clinical societies acknowledged that there was really need for direct evidence of a possible effect between taking an ACE or an ARB and an individual's chance of contracting COVID-19 or the severity of the disease. Now, these society guidelines offered some conflicting advice on to whether or not an individual should continue these medications. And mind you, these medications are fairly important for most individuals. They are known to decrease the risk of adverse cardiovascular events in people with hypertension. So there have been several observational studies that emerged to kind of examine this conundrum. But these studies suffered a number of problems. First of all, they were all rather small, involving maybe hundreds of individuals. They had very limited confounding adjustment. Individuals with hypertension generally tend to be older and also sicker. So perhaps that was what the association was modulated through and not the drugs that they were on themselves. These initial studies used very heterogeneous types of comparisons and had a host of methodological limitations that we'll talk about as we move forward. In some of those limitations, when you want to compare the risk of COVID-19 versus ACE and ARB usage, you don't want to do this when comparing that to an unexposed or a group of individuals who aren't using any antihypertensive medications, because those people are distinctly different. And doing so can result in a very non-comparable set of cohorts from which you're trying to draw inference, which can lead to both confounding by indication, right? We have individuals who are hypertension, maybe there's something else that's related here. And also with the non-use comparator, there's a real lack of sort of an index date, like exactly when did that non-user start not taking the drug, so that we can follow forward in time the user and their non-user counterfactual to see who ends up developing COVID more rapidly. So in order to overcome these issues, what we need as a community is really reliable evidence. And this reliable evidence should be reproducible, generalizable, and robust. So to draw strong conclusions from observational studies, we must observe, to meet these goals, consistent findings that can be produced transparently using well-designed analyses across multiple populations and data capture processes. All of the tenets that Patrick described when we kicked off this conference. We need to ensure that any association that we're going to report is not due to systematic error and is applicable in sort of wide populations. So the CHARYBDIS study aimed to determine whether exposure to ACEs and ARBs is associated with an increased susceptibility to COVID-19. And we did this using a large international federated active comparator cohort study, which distinctly differentiates our work from the unclear evidence up to that point. And of course, this was facilitated through the Odyssey community, its common data model, and tool stack. So let me start off by describing the data sources that we're going to use to answer this question. This is a federated network study. The results that I'm going to describe come from 3 different data sources. The first is the CityApp EHR. This is an EHR that covers about 80% of the population of Catalonia, so about 6 million people, and it includes all of the outpatient EHR information that's then linked to hospital admits, so we can look at severity in terms of hospitalization. We're also going to turn our focus towards a very large population-based rich EHR in the US that covers about 12 million veterans And this is both linked administrative claims that includes all all diagnoses, laboratories, prescriptions, lifestyle, and particularly a large number of social demographic measurements that are missing, like race and ethnicity. And we'll try to make these comparisons additionally across the 6 million people that are covered in the Columbia data warehouse. Now, I want to take a short breather and say that there's often criticism in a description of Odyssey's large-scale network studies that we make it seem too easy. And I really want to dispel that by drawing some attention to two particular individuals. We think of this pandemic as having wrought absolute devastation across the globe, but there's always a silver lining to almost anything. And the most important silver lining to me is this has been a real driving point in the community for us to expand and engage new, very rich active individuals and very rich data. And two particular data sources that were made available because we all came together as an open science community because of COVID are CityApp and the VA. And it took thousands of person hours, perhaps tens of thousands of person hours to make these resources available to us as a community. So the real Odyssey heroes in the COVID pandemic, I think, are both Talita Duarte Salez from CityApp and Scott Duval from the VA. So I'll describe very briefly the cohort design that we're going to use, and then fill in some of the details about the underlying methods. So instead of comparing a user to a non-user, as most studies had done previously, we're going to take a prevalent user design. So we'll look back in time before COVID started to spread in an area, and we'll look for the last prescription time that an individual had received a prescription for an ACE or an ARB versus individuals who had received a prescription for an active comparator. In this case, a different equivalent hypertensive treatment like a calcium channel blocker and a thiazide. And that last prescription time puts these two cohorts on equal footing in terms of their health status and their general well-being. Then we'll follow these individuals forward in time and ask how long does it take for each individual in these cohort to experience one of 4 different outcomes. And the primary outcome of interest really for susceptibility is a COVID diagnosis. But there can be difficulties in reporting of diagnoses. So we're going to also look at, in my short discussion, COVID hospitalization as a marker of more severe disease. Now, before this common index point in time, through the OMOP common data model, we have a wealth of information about these individuals. And we'll use that wealth of information before that index date to help assure that individuals in each of the 2 treatment groups are comparable before we move forward and ask, is there a difference in the relative rate in which individuals are diagnosed with COVID? In particular, we're going to use that large wealth of information to develop a large-scale propensity score model, which will use a nice data-driven approach through regularized regression. We'll then use the results from this propensity score model to balance the 2 comparator cohorts on all observed quantities that might also be associated with the outcome to help control for confounding by observed, confounding from things that are observed. At this point of index, as I said, we'll follow people forward in time, and we'll do a time to event analysis using a Cox proportional hazards model where there's a single indicator variable of which treatment did an individual has. This type of method certainly helps us control for observed confounding, but there could be a large amount of unobserved confounding that we'd also like to control for. And the approach that we'll take is we will use negative controls and empirical calibration to help adjust our analysis for any residual bias that might exist. Additionally, we're only going to move forward on analyses that pass a number of important study diagnostics that allow us to assess the reliability of the comparison that we're doing. So here's a chart of the number of individuals which are assigned to the different we assigned the different treatment cohorts across CITIAP and the VA. I don't really want you to look very closely at the numbers. The big take-home message is in this cohort study, we ended up following more than 1.1 million hypertensive patients from both the US and from Spain. If you do squint at those numbers, you'll notice some very reassuring findings. And that is there's less exposure to ARBs in CITIAP as compared to the VA, but this is due to different treatment practices in Spain versus in the United States, as we might expect. And not only did we look at individuals who were just taking an ACE versus individuals who are just taking, for example, a calcium channel blocker, but as a sensitivity analysis, we also include individuals who are on combination therapy, so an ACE and something else, because this is very common in hypertension treatments. And reassuringly, the individuals on combo treatment are larger than the number of individuals on mono treatment. So the first step in developing a reliable prevalent user cohort design is asking, with all of the information that we have about these individuals before index, are the two cohorts comparable, or can we make them comparable using large-scale propensity scores? So here are 6 plots. Each row is a different data source, so CITIAP, the VA, Columbia. Each column is a different type of approach. We might stratify by the propensity score model, or we might match by the propensity score model. And along the x-axis is the extent of imbalance. So how different comparable cohorts are before we try to do adjustment. So basically what the analysis would look like if you used one of these previous designs. And each of these points represent on the order of 10,000 different features that we have. On the y-axis is what that distribution of balance looks like after matching. And what you would like to see to say this is a reliable comparison is that after matching, these numbers are relatively small, say less than a rule of thumb of 0.1. So what do we see? At baseline, so before matching, individuals who take an ACE or an ARB versus those who are taking an active comparator are different. They're different in their prevalence of things like diabetes, kidney disease, heart failure, and atrial fibrillation. However, after matching, we pass diagnostics in the 2 larger data sets, CITIAP and the VA. So we feel comfortable moving forward and looking at the relative risk in these 2 populations. It turns out in Columbia, we were not able to fully adjust for different measured differences within these 2 comparisons, particularly for using stratification. In case you're interested, even after stratification in the Columbia data set, there were marked differences in pregnancy, renal transplant, and different types of treatment for heart failure. One might say that was actually a mistake in our design of the study, in that we should have realized that heart failure treatment could differ from database to database. Luckily, we have these diagnostics to tell us what are reliable and with which results can we move forward, even if design mistakes still creep in. So here are the primary results. what we're looking at on these plots, let's just focus on one. This is going to be the hazard ratio. So a number greater than 1 says there's a greater rate for an individual being diagnosed with COVID if you're using an ACE inhibitor or an ARB, and less than 1 means there's a smaller risk. Let's just look at the monotherapy results for our 3 different data sets. And when all data sets pass diagnostics, the meta-analysis that includes those that pass diagnostics. And very comfortably, if we look at the meta-analysis, which in this case includes the results from this CityApp and the VA, our hazard ratio is very close to 1 with a relatively tight confidence interval around that value, saying we do not have evidence suggesting that there's a differential rate of developing COVID diagnosis for individuals using ACEs or ARBs. Now, there was a side question in that rate that some of the pathophysiology raises, and initially there was some discussion that actually maybe ARBs are protective and ACEs are the ones that are going to be bad for you. So we do include a comparison directly of ACEs versus ARBs to try to bring some evidence to bear on this question. And for the most part, if we look at monotherapy results, we do not find evidence of a differential effect between ACEs or ARBs. If you look at the results very closely, you might see that for individuals on combo therapy with an ACE versus an ARB, particularly in the VA, there appears to be a significantly different hazard ratio than 1. As a matter of fact, the hazard ratio is set at 0.8. Confidence interval runs from 0.7 to just about 1. But the meta-analysis that pulls the results from CityApp to the VA together returns a non-significant difference. So maybe there's a difference between ACEs and ARBs. Even if it exists, it's very small. So no good talk is in general worth listening to if it doesn't mention some of the key limitations, which I'm sure you in the audience have already thought of their myriad limitations, but I'll just label a couple of them to raise some questions. Generally I'd say you'd like to use a new user design. But in this case, a new user design would be very challenging. So we went with a prevalent user design. What does that mean? Well, we might actually end up adjusting for mediators between being prescribed that drug sometimes in the past, the choice of taking that drug sometimes in the past, and the outcome. I don't believe that's a big issue when we're looking at something like COVID, because most of these drug prescription decisions were made before individuals were aware that this was an emerging infectious disease. So that, the emergence of COVID is very unlikely to have affected the decision to initiate one drug or another. And the biggest criticism to prevalent user design is sort of the depletion of susceptibles, or the ideas that we're going to look at a drug that's been on the market for a long time versus one that just came on the market. And so you might say, we'll take everyone who's been using it for quite a while, and you end up depleting the number of individuals that are left to put in the alternative group. But that's not here. These drugs have been around for a long time. They're relatively uniformly prescribed. And finally, there are always limitations in sort of defining what it means to be COVID positive. In this case, we used a combination of diagnosis codes and positive test results. It is very likely that these are real underestimates of the true number of cases. The amount that underestimates is naturally, it's going to vary by our data source. and you can think of it, it really depends on kind of the local area testing strategies. Local area testing strategy is probably actually better in Spain than it was across the VA population. And that's one of the reasons why we wanted to make sure that we ran this analysis across several different populations to sort of average over those differences. So here are some key conclusions to take home. First of all, the ICARIUS findings do support the initial regulatory and clinical society guidelines, although they were a bit contradictory, not to modify your ACE or ARB treatment based on COVID risk. So if you're currently taking an ACE and ARB, continue to do so. There's no evidence of a strong increased risk on these drugs versus an alternative, and there are good reasons to continue to take your antihypertensive treatments. There was some marginal difference perhaps between ACEs and ARBs, but they really don't warrant a class switch to reduce your risk for COVID susceptibility. If it is a true finding, it's on the order of 10%. It's not worth the risk of switching those drugs. So finally, no work is ever done in a vacuum, and very little of this was done by me. I'd like to highlight a couple of key individuals in the ICARIUS team. Chief among them are Daniel Morales, Mitchell Conover, and Chan You. So let me take a moment to thank those three individuals and everyone else on the team for a job well done. Thank you.